So you have a woman who gets THP, and she relapses in the brain plus systemically. Maybe she has a new liver met, but you know, 1 or 2 brain mets, and you know, and the brain. And so we're going to get into this in a minute. But let's assume for the time being 1 or 2 asymptomatic 1 centimeter brain mets because you scanned her brain for some reason and she has it. How would you treat her? Would you give her tucatinib in that setting or not?
I really would, because that's really the only data that we have besides addressing the brain with local therapy, you know,
Yeah.
doing some radiosurgery and all of that, which I think would probably not be a bad idea either. But the data that we have on DS-8201, it's a phase 2 trial. It's not that many patients, whereas tucatinib, it's a large phase 3 randomized trial, way more sturdy data.
Agreed. So Carrie, so what do you make of this whole brain business? You know, how many progressive Mets that are asymptomatic would you be comfortable with not giving systemic radiotherapy, not giving radiotherapy to, and just giving tucatinib to? That's the question I think everybody who's watching this is going to be asking themselves. Okay, a woman comes in the door, she's asymptomatic, she has to have a couple brain mets, you know, and what do I do with her?
So I think, you know, that would be a decision I'd certainly want to make with my local therapist, having the radiation oncologist also evaluate the patient, you know, making certain the lesion is not in the pons, because a brainstem lesion is going to be very different than a frontal lobe lesion. So really the location really matters as to whether or not you're going to lead with systemic therapy in these smaller asymptomatic lesions as opposed to radiosurgery. You know, I think lesions that are in the millimeter sizes and not in elegant areas, I would be very comfortable with the HER2 climb regimen as a lead-in. You know, radiosurgery certainly comes with consequences of radiation therapy necrosis, 9-12 months out from treatment. And the good news is that many of our patients are living 2, 3, 4 years after their diagnosis of brain metastasis. So being very thoughtful about when we position radiosurgery when it's absolutely needed. But I think that really, you know, it just highlights that multidisciplinary evaluation of the patient to make certain as the medical oncologist, I'm not missing an area in the brain that needs immediate local therapy.
So you don't have a number in mind? I mean, say a woman comes in with, say, 3 1 centimeter lesions, all non-eloquent areas. You know, who knows how much was eloquent, who.
Yeah, no, I think you're right. I mean, I think, gosh, I don't know that I have an absolute number in my head of number of lesions. I think any more than 4 or 5, I'm going to start to get nervous. I do think the 1 centimeter cutoff is a reasonable cutoff, because those lesions, if you follow a 6 millimeter, 7 millimeter lesion 3 months later, and I would definitely adhere to at least a 12 week, or maybe even earlier 9-week re-imaging brain MRI in the setting of an untreated lesion. You know, hopefully you would not see doubling during that time frame. And if you did, that would be a time where you'd want to go ahead and initiate local therapy. But I think, you know, sub-centimeter, 3-ish or less is very reasonable for systemic therapy first.
So Rashmi, was there a cutoff in the trial of the size of the, because there was a story, Erica Hamilton's telling us a story. You were there at that ad board when she said it. She said, I treated an asymptomatic woman with a 4 centimeter brain met and it went away. I'm like, what? I mean, was there really a limit, a size cutoff?
There was a size cutoff, but you know, with discussion with the medical monitor, you know, if the treating team felt like they wanted to defer local therapy because the patient was asymptomatic and didn't require it for any urgent reason, they could actually get a pass on the size cutoff. But I believe the size cutoff was 2 centimeters.
And there was no number cutoff, right? You could have as many as you wanted.
Yeah, right. There was no number cutoff.
So Mark, what would you do with the data? Would you do that too? Would you just treat anybody?
No, I mean, if it was a large lesion or multiple large lesions, I would feel uncomfortable relying on systemic treatment. However, with close clinical follow-up, with frequent re-imaging, you know, I'm not completely opposed to it, but I would do it under the auspices of our neuro-oncology group. We have basically a tumor board equivalent with the neurosurgeons, the radiation therapists, and ourselves. And so it would be discussed and we could adjudicate it that way with buy-in from the patient.